Welcome to the Aced It podcast, where we turn science into sense. In this very special season funded by the Bureau of Justice Assistance, we provide 10 timely episodes with the hopes of helping listeners understand what we can learn from current research that will help correctional staff. And please note, we did not just guess at what correctional staff need to know. We traveled the country, interviewing individuals working in prisons and jails, and the topics of these episodes are exactly what they asked for. So, I'm Danielle Rudes, your host, and here we go. In the final episode of this season of the Aced It podcast, we provide strong theoretical and empirical evidence regarding what prisons and jails and their staff can do to improve outcomes for everyone. To dive into the topics of reform, rehabilitation, recidivism, and programming, I'm going to lean heavily at first on an article written by Dr. Jim Byrne at the University of Massachusetts, Lowell, in 2019. Now, I know Jim, and I can say one thing he does consistently. That is to tell it straight. In this article, Byrne examines the effectiveness of prison programming by conducting a thorough review of the existing literature on programming in federal, state, and local carceral facilities. His specific outcome of concern is post-release recidivism. First, a bit of background. For a program to be considered evidence-based, Byrne notes that there are 3 types of reviews that allow for the establishment of quote-unquote what works. The most rigorous of these reviews is a high-quality, well-designed, randomized controlled trial, or RCT, conducted during a specific period. An RCT is an experiment with 2 or more groups, with at least one of them receiving treatment and one acting as a control group, meaning they get no treatment. And the people in both groups are matched so that they are comparable in some way or another, and they are assigned to the group's treatment or control randomly. Typically, to say there is evidence that something works, we'd need 2 randomized controlled trials at a minimum, and some other studies showing effectiveness. A second type of review is to show something works by including at least 2 quasi-experimental studies with positive findings and a host of lower quality studies, basically saying the same thing. A quasi-experimental study is really just a fancy word, but it's a study that's considered a little bit less rigorous than an RCT because although the researchers still use an experimental design with a treatment group and a control group, they do not randomly assign individuals to the treatment or control groups. They just end up there or they self-select. Finally, a third type of review to determine if a program or practice works includes a scoring process where at least 2 independent reviewers rates a program or practice as effective, and what their rating includes usually 1 RCT or a well-designed quasi-experimental study. This type of review is the type that's used by a website called crimesolutions.gov, a good source for finding programs and practices that may work in your prison or jail, by the way. Byrne uses option 2, which was the quasi-experimental plus some other study design, for the review in the article that we're covering today. Now, Byrne also considered 18 national model prison programs within the Bureau of Prisons, or BOP, which is basically the federal system. But these programs that he's looking at are applicable to state and county jail programs in many ways. So we're going to cover those programs, the ones that Byrne covered, pretty broadly. Basically, the news here is pretty mixed, with a little bit of hope dashed in for good measure. Byrne asks 3 questions about the Bureau of Prisons programming in his paper, but we're going to focus on question 2, as it relates to our context, state and local prisons. Question 2 is, what does a broader review of prison programming research conducted in state and or local prisons reveal about the risk reduction effects of prison programming? AKA, do these programs reduce recidivism? Byrne answers with some estimates about specific types of programming. So I'm going to go through each of these in turn. Number 1, for residential substance abuse treatment, Byrne finds 2 meta-analyses that were conducted in 2012, one by Mitchell and Company and one by Drake. Both of these found, this is a quote, significant though modest differences between individuals in therapeutic community treatment in prison versus those in control groups using rearrest during either a 1 or 2 year follow-up. unquote. It's some good news, but as Byrne notes, and we'll note here, 2012 is a while ago, so this research is a bit dated. Number 2, other types of substance use disorder and mental health treatment. The Drake study, from the example I gave you before, in 2012, also had some other findings, and they showed that recidivism reduction for other prison-based substance use disorder and mental health treatment like cognitive behavioral therapy, or CBT, counseling, and 12-step programs, their finding is that these types of programs reduced recidivism somewhere between 4 to 9%, but they couldn't report on longer-term effects of CBT programs. Those weren't available. Again, kind of good news, not overwhelming, but something to say, hey, that might be working in the right direction. 3, prison education and vocational education. The study showing recidivism reductions on prison education and vocational education relied on effects from other studies, meta-analyses, that were more than 2 decades old. However, those older studies did find somewhere between 5% and 12% recidivism reduction for prison education and or vocational education. More recent work estimates modest recidivism reduction for prison education and vocational education at around 5 to 10% recidivism reduction after somewhere between 1 and 3 years. Again, most of the studies are older, but the findings are trending in the direction that we would hope. 4, prison work and employment programs. Byrne notes that it's hard to provide an impact of the multitude of work programs in prisons because there aren't many recent evaluations. But the most recent studies did not find either a short or long-term recidivism reduction, and the programs do not also seem to have an effect on prison behavior. There is one, though, with some positive effects. It's a program called Employ, which links in-prison residents with jobs after release. So, what's the takeaway here? Don't provide programs to individuals incarcerated in prison and jail? Nope, not the message we're trying to convey at all. But the message is a bit tempered. We have some evidence to suggest some effects from in-prison programming, but the evidence is not overwhelming. It is not super strong or robust, and much of the evidence is fairly dated. But I am definitely not suggesting you put people in prison and give them nothing to do. No programs, no job training, no. Science suggests you're not going to get much positive change out of that strategy. However, if you are trying to get the best recidivism reduction results, there is something you can do that may increase your chances of success, according to Byrne and the data he analyzed, and I'll give it to you in his words. Quote, while prison programming is certainly one piece of the desistance puzzle, it appears that individuals will desist from crime upon release on a variety of individual and community-level factors. So, accurate prison-based risk-need classification that links residents at different risk or need levels to appropriate evidence-based prison programming should be followed by evidence-based reentry programming, unquote. This is especially important for substance use disorder treatment, mental health treatment, and employment programs and desistance. What does this mean? Well, prisons and jails should not guess what programs residents need, nor should they just put residents into programs because there is an opening or because someone feels it is a good fit. Instead, prisons and jails should use a robust risk needs assessment tool at intake and periodically throughout one's incarceration to assess individuals' risk and need factors for every person in their custody. Many U.S. prisons and jails already do this, but in my experience, one of 2 things happens. First, the risk need tool is completed and placed in a folder and not used much after that. And second, the prisons and jails do the risk need assessment tool and actually try to use it, but they don't have the programs available to address individuals' risks and needs, or they don't have enough of them or enough space in them. So responsivity, which is the matching of individuals to appropriate treatment based on their risk need scores, isn't possible. A risk need tool is just that, a tool. But it is only evidence-based if it is used to case manage individuals and help them match to programs that address their particular issues. So in this episode on reform and programs, I hope to, at the very least, offer it as a kind suggestion to prisons and jails that risk need tools are great. But the program infrastructure must be there to support individuals with particular risks and needs. Otherwise, you're just trying to figure out what people need and then doing nothing to help them with that need. Okay, so we spent a lot of time working through U.S.-based issues. Let me just broaden out a bit from the U.S. using an overview of global harm reduction programs in prisons that offer needles and syringes, opioid substitution therapy, opioid agonist medications such as naloxone, and diagnosis, treatment, and care for HIV, HCV, which is hepatitis C, and TB, which is tuberculosis. In a study entitled The Global State of Harm Reduction in Prisons by Sander and colleagues, the researchers overview the limited availability of harm reduction services for individuals with substance or opioid use disorders in prison and suggest some mechanisms for improvement. Currently, there are around 10 million people incarcerated across the world, and 1 in 5 of those people are held for drug-related crimes. In fact, according to this article, the UN AIDS, which is the Joint United Nations Program on HIV and AIDS, estimates that up to, quote, 90% of people who inject drugs will be incarcerated at some point in their lives, end quote. And data from the FBI finds that the U.S., in just the year 2017, arrested 1.4 million people for drug possession. That's 1 every 25 seconds. And most of these arrests resulted in incarceration. Additionally, and this is a quote from Sander and colleagues, the global response to drugs remains predominantly punitive, unquote. And research, as we know, strongly suggests that punitive responses to substance use disorder do not work. So why do I bring this up? You probably already know that the U.S. and the world incarcerates a lot of people, and you probably already would have guessed many of these individuals have substance use challenges. Well, okay, but there's 4 things I'd like you to consider. 1, substance use disorder is a disease that requires treatment, not just abstinence or punishment, to move toward positive outcomes. 2, drug use, including injection drug use, is linked to lots of other risky health behaviors, such as needle sharing, which is then linked to more health problems, including HIV and hepatitis C. 3, most prison residents do not receive substance use disorder treatment while in custody, and/or that treatment is not evidence-based. In fact, many prison and jail residents continue using substances while in custody, see our episode on K2 and fentanyl, for example, or they leave custody with the same addiction problem they had when they went in. And 4, there are evidence-based programs that do make a difference for substance use disorder and opioid use disorder that prisons and jails could implement. In fact, some are, and we covered some of that in the episode on MAT and MOUD in a prior episode this season. Okay, so where does that leave us for this episode? Let's return a bit to Sander and colleagues' findings. They note that punitive responses to substance use disorder leads to the denial of harm reduction services in correctional facilities, which consequently has contributed to the spread of HIV, hepatitis C, and fatal overdoses among the residents that are incarcerated. Harm reduction is a trending word in correctional circles that basically means exactly what it says. Programs, practices, and policies that think broadly to reduce harm in all possible ways. Like, for example, substance use disorder treatment is, of course, to treat addiction or substance misuse, but it also has a host of other outcomes, including improved health, because it lowers the risk of other behaviors or problems such as HIV, sexually transmitted diseases, Hep C, etc. This means it reduces harm in lots of ways, aka harm reduction. Many countries have implemented harm reduction programs, including opioid substitution therapy, OST, needle and syringe programs, NSPs, overdose prevention, and treatment for HIV and HCV, again, hepatitis C. And studies of these programs have overwhelmingly shown that these types of harm reduction programs have contributed to reductions in HIV and Hep C infections, improvement in the health of residents, and the mitigation of addiction. However, despite harm reduction services being widely endorsed by science and some community leaders, they remain limited in prisons and jails around the world. There is still a lack of understanding about harm reduction practices in prisons, preventing many residents from benefiting from their capabilities. What we must all keep in mind is that the provision of good quality and accessible harm reduction, both inside and outside of prisons, is not a policy option, but a legally binding human rights obligation and a critical public health issue. Now, since the United States is largely not on board with many harm reduction programs currently, and their availability around the world is growing, I'm not going to go into great detail in this episode about the ins and outs of each of these programs, but I will say a few things that Sander and colleagues report. 1. Opioid substitution programs are currently available in at least some form in 54 countries, but accessing these services is generally challenging for residents, and we noted this was the case for the U.S. in a prior episode. 2. Overdose prevention, a critically important harm reduction strategy, is also still growing in use. Only a handful of countries, including the U.S., provide naloxone to residents in prison or upon release, and little is known about the practices involved with distributing naloxone. But the opioid epidemic is not waning. On this issue, we need to get on board to save lives. 3. Regarding HIV treatment in the U.S., Sander and colleagues report that only 37.9% of people newly diagnosed with HIV in the U.S. prisons were linked to HIV services within 90 days, and funding, they noted, is the major issue. Regarding Hep C, Sander and colleagues reports on another study by Byrne and colleagues, 2014, that found in their study, routine testing and treatment is available in less than a third of U.S. carceral institutions. Additionally, Sander reports on a 2016 study by he and colleagues of HCV screening and testing in prison and found, quote, implementing risk-based and opt-out screenings could diagnose up to 122,700 new HCV cases in the next 30 years, avert up to 12,700 new HCV infections, and prevent up to 11,700 HCV deaths. Now, if you work for a prison or jail or do research inside these institutions, you likely know that even despite our best risk-need responsivity models and our best and most forthright intentions, some residents simply do not want programs. That is true, but let me help you understand why. I will transition now into a 2022 study by Kaiser and colleagues. The researchers here report that a large body of research suggests that residents choose to participate in programs for two reasons. 1, readiness for treatment, and 2, motivations for educational programming. This means without treatment readiness and motivation, some residents may not want programming. Why? That's what Kaiser and colleagues set out to find. In a study of one prison in the southern U.S., the researchers distributed a survey to male residents in 2019 in a medium maximum facility. Using the 212 completed surveys from a group of residents that were comparable to the residents in the facility population overall, the researchers found three main things. 1, when there was a lack of space for programming, or when residents thought the programs were not offered or available enough, their participation in these programs was more limited. 2, residents who perceived the prison as legitimate, were interested in available programs, had a higher self-esteem, and were at the facility for 6 or more months, all had higher program participation. Incidentally, legitimacy and self-esteem are also associated with lower offending and lower recidivism, according to several other studies. 3, residents with greater self-control, less depression, less anger, and greater perceptions of procedural justice, meaning again that the processes are fair, were more likely to report that they had no barriers to program participation. Kaiser and colleagues strongly suggest that carceral institutions pay particular attention to these characteristics if they want to increase prison program participation, and a note from me. Many of the problems with program participation are exactly what the residents would learn in many of the programs if they would participate. It is important, in fact, super important, to find ways to entice residents to participate for that reason and so many others. Okay, so we've covered some fairly limited evidence regarding prison programming's effect on recidivism, and in large part this is due to poor or lacking studies. harm reduction programs, and reasons why residents may or may not want to program. Let's wrap up this episode with something that adds a bit of sunshine. Prison gardens. Prison gardens have both a historical and contemporary place in carceral institutions. They provide skills, opportunities towards self-sustainment, including growing your own food, and they are often used as a form of correctional employment. However, they have also been linked to physical, social, and mental health benefits, such as improved cognitive function and increased restoration thought processes. That comes from a study by Kaplan in 1995. In a study conducted by Timler and colleagues, though, more recently in 2019, the researchers discussed the amazing good that can come from growing produce in prison. Now, this research is qualitative, meaning that the researchers conducted observations and interviews with residents working in a garden, 10 of them, the indigenous community members who received a portion of the produce that they grew as a donation, 10 of them, and stakeholders of the garden, 5. Now, hold up. I can hear you judging. 25 interviews total, qualitative, schmalitative. All right, well, hold on. I'm a qualitative researcher, so please don't judge. And like quantitative methods that get us some outcome measures like recidivism reduction are super important, so too are the voices and experiences of people in their own words. The power of narrative accounts is equally as important. So before you get all too dug in your, that's just soft science rant, can I ask you to trust me? There is value in this work. I promise. Timler and colleagues found substantial benefits for the men who participated in the prison garden. These benefits included accessing fresh and nutrient-rich vegetables and feeling a sense of pride in their work. They actually experienced feelings of pride in prison. Now that's worth noting, and certainly a good outcome. Additionally, the researchers found that the donation of produce brought joy and accomplishment to those who provided food to insecure communities. It was evident to the researchers that many of the residents participating in the garden had grown up in a food-insecure home. So working in the prison garden provided many residents with an opportunity to reflect on their own experiences and lives, but in turn, they were able to imagine their future in new and positive ways. They learned that they can be helpers. They can help themselves. Good and good. To give you a bit more on their experiences, let's hear from the gardeners themselves. One resident said, quote, "Everyone's worried about the cost of social programs. Well, what's it cost to have people out on the streets that need food, that cannot afford to feed their kids? Down the road, it's going to be hard on those kids. I grew up without food. Unless you do something to help people that need help today, it's just going to be an endless game of trying to make things better. You got to give people hope and something to work with," unquote. Another resident noted, quote, "It's my joy, you know? I mean, a lot of people say, well, it's a lot of work, isn't it? No, it's not. It's something I thoroughly enjoy. I get a lot of benefits out of it, and the pleasure of being able to go somewhere and take a load of veg and see the reaction on people's faces." So this study underscores the potential of correctional agriculture programs to help foster healing, rehabilitation, giving back to the community, and reintegration for incarcerated individuals. That is certainly not something you see every day in prisons and jails, but wow, what if it could be? In this season finale of the ASTIP podcast, we have explored a lot. Key strategies to improve outcomes in prisons. We have highlighted the need to address the punitive culture, the importance of harm reduction strategies, how to overcome barriers in participation in programs, and implement innovative approaches. And we've even talked about impactful programs like prison gardens. This, by no means, covers everything possible regarding programs and reform, but it's a good dive into some key issues that every prison or jail should be having conversations about and trying to find ways to improve or implement. Okay, let me just take a little step back and say, as we wrap up, I want to remind you here that if you work in corrections, you are not alone. Figuring out what you need, what might work, and how to implement things in your prisons and on your limited budget may seem overwhelming and frustrating. But again, you are not alone. You likely already use community members as volunteers for some of your programming needs, so why not also work with researchers if you're trying to improve outcomes, trying to find and implement programs, and trying to report positive findings. As I noted in a prior episode, researchers can often secure funding from external sources so you won't even have to pay for their services. They can work with you, partner with you, and help you get creative and or work toward achieving your goals. Then, after you're successful, they can present these findings at conferences and events, sometimes with you too. So other prisons and jails in the U.S. and beyond can see your institution or your system as a model to emulate. That would feel good, right? So if you got into the corrections profession to help people, and many did, but now you feel stagnated, beat down, or unheard, reach out to me, Danielle Rudes at Sam Houston State University, DRUDES@shsu.edu. My carceral research team can and will help you. Either we will do the research or the training that you need ourselves, or we will help you find local researchers to help you. Research is not supposed to be about creating exposés of all the failings of your prison or your jail or your system. Instead, it can and should be about helping you get back to that helping people goal that you set for yourself many years ago. We are here to help you so that you can help yourselves and others. Let's partner to create impactful trainings and research of consequence to work toward and obtain a better and more humane future for us all. Thank you for listening to the ACED podcast. We love hearing from you. So if you have comments, topics to suggest, or some research you'd like us to cover in a future season, please write to me, Danielle Rudes, at Sam Houston State University. My email is drudes@shsu.edu. And now, a whole bunch of thank yous. First, this project was supported by a grant 5PBJA 22AG00031 MUMU, awarded by the Bureau of Justice Assistance. The Bureau of Justice Assistance is a component of the Office of Justice Programs, which also includes the Bureau of Justice Statistics, the National Institute of Justice, the Office of Juvenile Justice and Delinquency Prevention, the Office for Victims of Crime, and the Office of Sex Offender Sentencing, Monitoring, Apprehending, Registering, and Tracking. Points of view or opinions in this podcast are those of the host and the research team, and do not necessarily represent the official position or policies of the U.S. Department of Justice. Then, more thank yous. Thank you to the Justice Community Opioid Innovation Network, or JCOIN's Coordination and Translation Center, funded by the National Institute on Drug Abuse, housed at George Mason University, where this podcast originated. Thank you to our fabulous scriptwriter, SHSU master student Jalen Magana, and to my amazing research team at both Sam Houston State University and George Mason University. The team includes Bryce Kuchmarek-McCune, Sydney Engel, Caitlin Bauer, Shalom Aganaya, Alexa Mata, Chelsea Narvi, Alyssa Toman, Miltonette Craig, and Wyatt Brown. And a huge and heartfelt thank you to Jason Luton and the team at Slonky LLC for their fabulous podcast production. Tune in again soon for another episode of Aced It.